As we emerge slowly from the fog of COVID-19, the conversation now turns to what now? And what's next? Hi, I'm Phil Febbo, Chief Medical Officer at Illumina. Our upcoming panelists have played different key roles in fighting the pandemic over the last year and are a testament to the united global effort by the scientific and healthcare communities. Joining us today will be Dr. Scott Gottlieb, a special partner at the venture capital firm New Enterprise Associates and a resident fellow at the American Enterprise Institute. From 2017 to 2019, Scott served as the 23rd Commissioner of the Food and Drug Administration. And throughout COVID-19, Scott has provided his clarion voice, helping us understand the need for diagnostics, vaccines, and how we can continue to keep an eye and fight the pandemic. We also have Dr. Eric Topol, founder and director of the Scripps Research Translational Institute and professor of molecular medicine and executive vice president of Scripps Research. Eric is one of the top 10 most cited researchers in his field, where his principal focus has been on genomic and digital tools for individualized medicine. Professor Tulio de Oliveira is a bioinformatician and the director of the KZN Research Innovation and Sequencing Platform known as CRISP, a state-of-the-art laboratory that's played a critical role in supporting the public health response to COVID-19 pandemic in Africa. He received his PhD at the Nelson R. Mandela School of Medicine in South Africa. Tulio's team was fundamental in identifying the emergence of variants. It was his team's work that identified B1351, a variant that emerged in South Africa and has found to be more resistant to some of the neutralizing antibodies and more transmissible. And finally, Stacey Gabriel is Senior Director of the Genomics Platform at the Broad Institute of MIT and Harvard, where she has led platform development, execution, and operation since the Institute's founding. Stacey is the chair of professional scientists and serves on the Institute's executive leadership team. In response to COVID-19 pandemic, Dr. Gabriel led the development and execution of Broad's scaled-up diagnostic efforts, including testing 100,000 individuals daily during the pandemic at the peak. Thank you all for joining us today. We're going to start with what we know and what we know we need to do to control this pandemic. We need to continue measures of social distancing. We need the vaccines, and we need to distribute the vaccines, and we need adoption of the vaccines. We need to continue to test and trace and quarantine those found to be infected. And finally, we need genomic surveillance. Each of you have played a critical role in different elements of this, in multiple elements of this. I think I'd like to start with you, Scott, and start about vaccines and the distribution of vaccines and some of what we're seeing out there, vaccine hesitancy in different populations. Can you talk a little bit about the role that vaccines are currently and will play as we look to kind of bring this pandemic to an end?
Thanks for having me today. I think the vaccines are one of the great achievements during the pandemic. We crossed a technological inflection point where we were able to fully synthetically derive vaccines. If this pandemic had struck 2 or 3 years earlier, we wouldn't have had the technology available to do what we were able to do, which was derive vaccine constructs almost entirely from the genetic sequence of the virus. With respect to the supply of the vaccines and the ability to get the population vaccinated, I think as we get into the spring and the summer, there's going to be ample supply. And I think we're going to find that their demand is less than the supply, that the supply is actually outstripping demand. That hasn't been the situation that we've been in as we rolled out these vaccines. But I think we're going to need to do more to stimulate demand. And it's not just a question of vaccine hesitancy. There are clearly some people who are hesitant about getting the vaccine. But there's a bigger pool of people who just either are complacent about it. This isn't a vaccine right now that's being distributed in a way that's convenient. As it gets into more retail locations, into more pharmacies, as we start to push it into doctors' offices and certain hard-to-reach communities, I think that that's going to help solve some of that challenge. But I still think that we face obstacles getting this vaccine broadly distributed. And we may get to 50% of the adult population vaccinated. I think we'll probably get to 60%. But I think beyond that, it's going to be a struggle, and we may not achieve higher vaccination levels until we come back in the fall. And then people are looking at the sort of fall-winter COVID season, and they're remotivated to go out and get vaccinated.
I do want to pick up on the issue of complacency and move over to you, Stacey. the broad has been far from complacent. You guys revved up diagnostic capacity, getting to 100,000 tests per day. We've seen in the United States, initially it was the big focus on testing last spring and summer. We got up to about 3 million tests a day, but now we're, seeing a decrease in that. Yet we know people vaccinated can still be infected. We know the best way to kind of continue to move cases lower is to continue to test. Maybe you can give us your sense of what you're seeing now at this stage of the pandemic with respect to testing and tracing and different institutions you've worked with.
It's true that I think that there's fewer tests being performed, I think, overall across the nation is what I've seen. However, a lot of the testing that we've supported, that we've sort of designed around, is really aimed to increase accessibility of testing, having a low-cost test with a fast turnaround that can scale. And so as such, we're really used quite frequently in the setting of asymptomatic testing in nursing homes and colleges, in workplaces, where really, there is this notion of repeated testing to sort of keep an eye on things. And so for us, at least locally with our set of users, we haven't seen much of a decline. We're still cruising at around 120,000 tests 5 days a week when the collection sites are open, slower on the weekends. But we haven't seen that. I think that if people are solely in the mode of only testing those who are symptomatic, I agree, that's probably where you're starting to see the decline, but we've certainly seen the value of keeping up some of the routine testing of everybody to make sure we're keeping an eye on where infection is going to happen, which could happen.
Yeah, and testing gives us an idea whether someone is infected with SARS-CoV-2. Tulio, your group started raising alarms that it's not just if you're infected, but what variant you're infected with. And certainly now there's much broader awareness of the importance of genomic surveillance. Maybe you can talk and bring in your perspective on the surveillance aspect and how you've seen that ramp up and where we are right now with respect to global surveillance.
So what we did in South Africa, and then we helped with the Africa CDC in the rest of Africa, is to do a very consistent genomic surveillance that we are sampling every week across the country, and now we are helping 10 other African countries to do random selected samples to just understand what's the diversity of the different viruses circulating the continent. In addition to that, what we also did is to get this very close partnership with the clinical staff. So what they did once they see the numbers growing very fast, the first person of contact end up being us at CRISP. And then within days, we can receive samples and to sequence. But more important, to activate a network that could sample all the area across that area that's growing number of infections. And we end up identifying a new variant quite early. That was end of November, beginning of December. And that's what went to make the whole world to realize that these variants are important. And we also help a lot of our British colleagues to identify the one. But probably the most important thing in South Africa, and it has not only been the genomic surveillance, it is this new and exciting field that we call genotype to phenotype in real time, that within days of identifying a new variant, we can get the virus to be grown in a lab, a live virus, and also pseudovirus. And we can start exposing this virus to different vaccine convalescent plasma or people that was recently infected, and end up understanding what's the effect of these new variants on decreased neutralization and transmission. And that's what we are quite excited. It is to really be able to use not only genomic surveillance, but all these other advanced lab techniques to understand what would be the most effective vaccine or the most effective intervention for a different area.
Your comments really underscore Scott's earlier point, how, in so many ways, this pandemic has shined a light on technologies that we have where we can really understand this virus in real time. We can use the genetic sequence to print out RNA to start vaccine development. And as you said, we can go into the lab and as we see variants, look at their impact on, the efficacy of neutralizing antibodies. Eric, in the United States, we were, I know Scripps was, advocating for genomic surveillance from the very beginning. You and Christian Anderson were doing genomic surveillance. And, but it was really not until Tulio's work and the work from the COG UK that, we saw in the United States incredible enthusiasm for it. Maybe you can talk a little bit about how Scripps, was championing that and then how you ramped up your efforts.
I think the genomic surveillance story is critical, of course, and exemplified by, as you say, COG UK identifying the B117 and Tulio and his colleagues with the B13151. Now in the US, Christian in the lab we have at Scripps Research picked up the second person with B117. We wouldn't have known about it if it wasn't for COG UK. So our surveillance has been, very spotty. We were one of the sites that was supported by CDC spheres, but it wasn't getting the support from the prior administration that was necessary. That's changed now with the $200 million and also the rescue package to bring robust support for genomic surveillance. But, as Tulio emphasized, it isn't just the genomics. The point here is that, everyone knows we have a long history in genomics of really fixating on the variants in human genomics and not getting the functional correlates. And that the immune assays and understanding the functional correlates are so vital because, the term I coined of scariants, which is what we have lots of variants that are innocent. We have to know which ones are engendering immune escape, which ones are leading to high transmissibility or virulence, lethality. And that comes from, as Tulio emphasized, these real-time assays. So in addition to that, we don't want to be just genomics fixated. We want to be surveillance at multiple levels. So, what Stacey mentioned about testing, why don't we have home rapid testing to every household? Slovakia is, they were able to contain their outbreak with nearly 6 million tests that were administered throughout the entire country. Why aren't we doing this in the United States? And also their digital surveillance, that is the ability to monitor physiologic things that are passive on a smartwatch or a Fitbit to know whether there's asymptomatic carriers out there and to be able to control and contain outbreaks. So although genomics is the topic here, clearly there's lots of different multi-layers of data that are important to get the full composite picture.
So as we think about sustainability and the willingness to avoid cycles of panic and neglect that we've seen historically with other pandemics, Scott, maybe we can turn to you and talk about the United States and what you've seen as far as the United States, investment and preparedness to get through this pandemic and set up systems for future preparedness.
Well, look, I think what this demonstrated is we didn't have the resiliency in the system that we thought we would have. And we had done pandemic planning back in 2005 in anticipation of the risk of a pandemic flu that would involve a novel strain of bird flu, which is what we were worried about. And a lot of our planning was very pathogen specific. It was focused around the risk from a pandemic flu. I think we anticipated that we would have enough testing in place in the setting of an influenza pandemic, although you wouldn't use testing in the same way that you've used testing with COVID with respect to a flu. But none of the capacities that we thought we would need were really in place. I mean, even the strategic stockpile, it was sort of a metaphor for the challenges that we faced. We didn't have the reserves in the strategic stockpile. We ran out of nasal swabs. We ran out of testing reagents. We didn't have enough N95 masks. The ventilators that we had stockpiled didn't work. So I think we're going to need to think about public health preparedness as a matter of national security and look differently about how we build those capacities. Flu was a relevant place to start in our pandemic response to COVID, and a lot of the early measures that we adopted were based on our assumptions about how flu would spread and how we would prevent contagion from a novel strain of influenza. But we also didn't learn fast enough.
Tulio, from South Africa, as you look at your government and the countries in your region, how do you see the kind of transition from this kind of acute intervention? Obviously, it's ongoing, but sustaining the efforts to continue to control this and be ready in the future.
One of the things that may indirectly have helped us in South Africa and Africa, is that we got quite used with epidemics and pandemics, and that's one of the reasons why a lot of the counter scientists could pivot so strongly to COVID, In order to build sustainability, what we have done, not only across South Africa, but the region, is to survey like probably the 20 most important pathogens that even had currently causing epidemic in Africa. So at the moment, in addition to SARS-CoV-2, we have big epidemics of HIV, of TB, of hepatitis C. But we also starting to look at viruses before they cause zoonotic transmission. So we are setting up a number of teams that are surveilling, for example, a lot of our biodiversity, and especially we are talking mostly about mammals, and looking for virus that may cross to the human population in the next few years. And interesting, technologically is exactly the same process. There's no much difference to sequence SARS-CoV-2 than to sequence HIV or bacterial TB or West Nile or Rift Valley. So that's what we have done. We have built now these pandemic potential pathogens. And what we are doing is starting to do surveillance both at human population, but also at potential cross-zoonotic transmission. And we think that's going to be crucial in the next few years and decades, is that either we identify these epidemics and this virus reservoir before they cause a massive epidemic, or that we identify that very quick, so we can kick, as was mentioned, with good diagnostics and vaccines and protections.
Yeah, so that's really interesting, Tulio. So, when you look at Africa and you see, the organisms with, pandemic potential, the future threat sounds like feels more real to you. Stacey in Boston, maybe a fewer pathogens of pandemic potential. As you've engaged with, local health authorities, local institutions, the Broad has really played a fabulous role educating public health jurisdictions and enabling public health to get to sustainability. What's your perspective on our transition to sustain our efforts, finish this pandemic, and transition into future preparedness in a sustainable way?
Yeah, I think for us, it's been, such a learning experience in building these connections, like, as you say, to the folks in public health, to the local, to the DPHs in the region. Something that, we'd like to become more sort of involved with is the rapid surveillance screening, because, really what I've seen is so often when the surveillance sequencing is happening, it's, the sample was collected 2 weeks ago, for example. The diagnostic test was run 2 weeks ago, but there's this lag between the diagnostic labs transferring it, doing the sequencing. So we're trying to really tighten that loop to hopefully give more sort of rapid feedback so the DPHs can react. So that's, I think, something that, just given the setup now and the linkages that we've now built with DPH and CDC, that I hope that we can extend into the future. I'm sure there might not be the wide variety of pathogens that there may be elsewhere in the world, but, I think we do want to be prepared in that way with those connections.
Yeah, and your comments really raise an important issue in that there's 2 points that I'd like to pick up and move to Eric, because it's a special expertise of his as far as data. So there's the public-private partnership. Eric, you mentioned you at Scripps already working with the CDC in that kind of a way where the CDC can really benefit from the expertise and the capacity that the Scripps have, and with Christian Anderson's lab and what you've developed at the Translational Institute. But sustainability is also an efficient use of resources and, gathering large amounts of data, sorting through those data, looking for a signal. Maybe you can talk a little bit about that on a sustained basis. Where do you see that happening?
Well, that gets a little complicated in the U.S. because we have a fragmented health system with electronic health records, and it's all balkanized. It works a lot better in the UK and other countries where you have universal health care, and that this is not such a big issue. So the linking with the patient records is another ancillary layer that's quite important. Otherwise, the analytics here, when you're just self-contained, when you're just trying to understand the relationship of the sequence to the functional correlates, that's a different story. But when you're trying to link it much more broadly, it's tricky. But another layer that I should have mentioned is, of course, wastewater surveillance, which has been used in many locales for picking up not just days or several days, a week before it shows up in the community, but even the variants have been diagnosed. So, this is just part of the challenge here, Phil, that you're bringing up. It is a very complex data with all these different layers that should be ideally integrated in real time with processing and feeding back to the principal parties of interest. And no one really has been able to do that. Perhaps, we've seen the best examples are CogUK and CRISP, but, we haven't yet assembled that parts here in the US.
In South Africa, what we did, we built some experience, not only in South Africa, but we participate a lot in the previous epidemic response from both HIV, TB, Zika, yellow fever, chikungunya, dengue. And so we got a little bit used on doing genomic surveillance. And what we did very early is to follow a lot the UK example, the COG UK, and as Eric Topol highlight, And we went to the whole country and say, if you want to do something that would work, we're going to have to work together. And one thing that helped us is that in South Africa, not as effective as the UK, but we also have a national labs, the National Health Laboratory System, which allow us to link to the patient data very, very quick. And that was crucial, this strong link between where the sample comes from with clinical information. And then what we had to do, we had to build this layer of also communication with the Africa CDC, the Africa Center for Disease Control and Prevention, to do that across other African countries. One thing that maybe many people is unaware, but that also helped us, is that normally some of the big economies in Africa, like South Africa, Nigeria, and Kenya, it's already the testing center for most of the pathology labs, simple labs across the African continent. So it's quite effective to import samples very, very, very quick. And then what we have done is to build this layer that we would get samples from other countries, produce the genomic surveillance results, but first to communicate with the government. And then only when they go public, which normally is just a matter of days.
It comes to the idea, in order to really, the value of that data is the value of sharing, and yet there's this balance between the public health needs to respond and then protection of individuals' privacy. And, I think, Eric, you've spent a lot of time thinking about how, medicine is moving much more towards a data-driven, real-time data-driven practice. How have you seen the data sharing facilitate, the response to this pandemic?
It hasn't been at all adequate, Phil. I mean, ideally, everyone should be able to look at their phone and see all these layers of data, the mobility, the spread, the variants in their region, in their neighborhood, the testing results, everything. So we can get there. The idea is that it's not just data for some central public health authority to see, but for everyone to have access, because we all get smarter faster and we all cooperate more to try to prevent spread. So I think that's the target, is that we have data that's also flowing back to all people, and it's a worldwide goal.
Yeah, and Stacey, with the 100,000 tests a day, that's a lot of diagnostic tests to report back to individuals. And I'm sure there were public health entities interested in summary data. Like, how did you see that play out with what the Broad was working on?
Short answer, I would say pretty painfully over the months, learning how to hook up that sort of resulting into the electronic medical records of many different institutions. It was just something that was new to us, certainly. And so Yeah, there was a big learning curve, and you really do start to feel that point that, Eric brought up earlier, the lack of we have all these fragmented systems, all these EHRs, and so there's a lot of linking up to do. And so that's just the diagnostic test, which is a yes or no. Now, as we start to think about surveillance sequencing, the question of how we're going to flow that information back in an effective and understandable way, I feel like we're just starting to get our hands around, and we're probably, well, I don't think probably, we're too late in the game to just be figuring this out now. So I think, it's all hands on deck to figure out how we're going to effectively communicate that information back to, like I said, to shorten that loop, hopefully, and get that information where it needs to be for things like contact tracing and containment much more quickly than we've done so far.
And Tulio, how are things doing with CRISP, getting that information back?
Yeah, a lot of our previous panel members, they touching very important things, such as Scott on the resilience. Yeah. So what we did at CRISP, at the Network Genomic Surveillance in South Africa, we divided our sequencing capacity, what was quite limited, in 3 different areas. Yeah, one was a continuous genomic surveillance in the country, week by weekly. The other another third was to help other African countries. And another third, we keep quite idle, yeah. So we could respond to very important questions. So for example, if you have like 1,500 genomes of a vaccine trial, yeah, we can sequence all the breakthrough infections very quick. And we have done that for the AstraZeneca, for the Novavax, for the Johnson & Johnson. Now we are starting to do with the other big trials, yeah. And that kind of thing is very important to have this resiliency and extra capacity to respond to the most important questions very quick, even with limited effort. And I think that the whole world is going to think a little bit more on have this extra capacity that can kick quite quick. Yeah. In relationship to data sharing was also quite interesting, because what we did is a process was a little bit radical. Yeah. So what it means, our bioinformaticians are not allowed to touch any data until the data is public. Yeah. And that's just to make sure that the bioinformatic teams assembling the data, it's focused on releasing the data public so people can analyze. And we found that paid off. Yeah. It made much quicker data release, because then the bioinformatic team now, it's interesting on really cleaning the data. And the other things about talking to governments. So we normally give the data first to the government, and we tell them that's of the great interest to go public, especially a country when detected a variant. So one thing that this pandemic teach us and the whole international community, that one should share data before analyzing, should release the paper before peer-reviewed, yeah, because that kind of things allow one to react much quicker.
Yeah, and that really facilitates kind of that informal sharing, that rapid sharing. Scott, you talked about how there are disincentives at a national level to formally share, but perhaps the way to have, global sharing occur is through kind of those individual efforts.
Yeah, I think there's going to be an effort to try to enforce sharing of information, early information about outbreaks. And that's really what we want. We want early awareness. We're going to go back to the WHO. We're going to strengthen the international health regulations. The Biden administration has already talked about that. I think the global community will come around and do that. But I don't think we can fully depend on the global system any more than we were able to depend on it this time, any more than we were able to depend on it with SARS-1. We have now ample episodes where China has been host to unusual strains of bird flu, where they stopped sharing the viral samples. I mean, in recent years, they've stopped sharing viral samples. They have not released sequence data of pathogens we know that they have sampled. Hopefully that will improve after COVID. Hopefully the world's learned some lessons, but I don't think we're going to be able to fully trust that. Now, some of the bilateral collaboration between researchers is the bright spot, and we can strengthen those direct engagements, invest more in some of the scientist to scientist collaboration. And where you saw a lot of collaboration happening, though, was among the provider community and among the academic community in the academic institutions, where informal networks that didn't necessarily exist before the pandemic were created, and doctors and providers and researchers were sharing information in a very fluid fashion. I think social media became a very important tool for sharing information. Twitter became an extremely important tool. We saw for the first time social media become a way to disseminate information. We saw the advent of preprint publications on preprint servers become a very important tool. I mean, think about all the publications that appeared on preprint servers and how few had to be, retracted or really rethought in a fundamental way, where they weren't contributing to the scientific dialogue and advancing the science. And in a few instances where you saw us get it wrong, there was a lot of work for people to reevaluate findings. So I think that those informal networks worked exceedingly well. And I think what you're going to see after COVID is some of those interactions become formalized, because it allowed us to learn in a real-time fashion here.
I was just going to say, Bill, that I had nominated Scott back March last year to be the czar of COVID for the country, to pull it together. If only that had happened, we would have been much better off. I don't think we could have been much worse off, but unfortunately it didn't go over.
Yeah, and Eric, I was going to go to you as far as, your voice has also been one of the consistent and, very helpful informal voices through social media to highlight important scientific work, to provide a perspective that's engaged. And, how do you see that? How do you see countries like the United States, where there's more fragmentation, moving to more sustained partnerships, like Scott's saying? How are we going to do that? Are you optimistic about that? Are you concerned? Where's your perspective right now?
Oh, I am optimistic. I think we're heading towards the phase of containment here, and certainly globally. And I think we learned so much from this cooperation and this information exchange. It has to be rich. It has to be, continuous, and it has to be truly a global network, as Tulio outlined. This is essential. If we learn one thing, we can't be nationalistic, and we can't be, without a policy that extends throughout our country. This idea of having each state to be on its own here in the U.S. has been a true fiasco. And we're seeing it right now. In fact, it's undoubtedly going to prolong the pandemic unnecessarily, because here we're confronting the emergence of the UK variant. And we have many states that have gone fully open and got rid of their mask mandates and whatnot. So in order for us to, be in synchrony, it's not just our country, but, it's the species, it's the planet. And we got to think planetary all the way.
Stacey, what are your thoughts? What do you see as far as the transition toward global understanding of this pandemic? And, appreciate your perspective.
Well, I certainly look forward to the future of better point-of-care diagnostics that are much more distributed, much more just generally available, cost-effective. I mean, it is quite surprising to me. I mean, I was pretty convinced our lab would be out of the PCR business over the summer. I thought by that time, there has to be some simple over-the-counter, pregnancy test-like sort of capability that someone could just screen quickly and cheaply. And so I do hope that that's a reality. I think that there are some promising technologies coming out of the Broad and elsewhere. Certainly that could help the U.S., that could help the developing world for sure. But that should be something that we don't take our foot off the gas pedal here. I would say new tests, and also I can tell you just how intensely aware of supply chain I have become, how fragile supply chain is in a number of counts, so even the simple things. And so I think also looking forward to even not thinking about fancy new technology, just a greater awareness of where everything is coming from, and having multiple sources and reducing as much as we can. I can tell you, even in our sequencing operation, we've taken parts of where we used to use 15 pipette tips and now use one. Just with this notion of let's conserve, and we should do that forever, not just during this pandemic. So I think it's both technology and supply chain that I really think about going into the future.
We've learned a lot in this past year. We need to continue to embrace those learnings to get through the end of the pandemic. We're not going to get the end of COVID or SARS-CoV-2. I think that's going to be part of our communities going on an ongoing basis. But what are some of the major learnings that you feel that, will put us in a better position? And maybe Tulio, starting with you.
I really like Stacey's comments, because by running also genomics lab, of course, much smaller than the Broad, I do get worried about the environment also and the amount of plasticware that we use. We did the same as both reducing reagents and also creating much straightforward plans and processes. Going forward, this virus basically surprises us every few weeks. So at the moment, we as a global and international community, we are quite confident that the rollout of the vaccines will slow down a lot of the pandemic, which is fantastic. But I think that we have to keep our eye. We have to keep our eye on the ball. And keep it surveying. And again, what Eric highlighted that was very important, and really run away from this vaccine nationalism. 3 million vaccinations in the US in certain day, but some countries, healthcare workers not only didn't get a single vaccine, but they also didn't even got paid because the health system is so weak, that you are putting our frontline responders, in a very fragile situation. So I think that we have to really think as a global problem, and something that we like to repeat: no one is safe until everyone is safe, and try to control this pandemic everywhere in the world. Otherwise, I think that this virus may keep outsmarting us. And one thing that we know is that that can be big jumps on mutational profile. And we hope that as controlling that around the world, we can avoid that.
Scott, as you think of, the learnings from this past year, what are the most important learnings that we have to keep front of mind that will really put us in a better position moving forward?
Well, look, I think there's going to be a reauthorization of the Pandemic All Hazards Preparedness Act earlier than that bill would get reauthorized. I think they're going to take that up probably in the fall, would be my guess. I think one of the bigger consequences of this, if you will, is going to be that we've always relied on international conventions and global sharing to get information about outbreaks and to share strains. And we relied on researchers and public health officials being able to work together. And we're going to try to reinvigorate those multilateral agreements. And we did that after SARS-1. We updated the IHR, the International Health Regulations, and required more mandatory reporting of outbreaks. And we found once again, it broke down. Once again, the information wasn't shared in a timely fashion. We never got the source strains from China. We had to get them from third-party nations and had to wait until we had outbreaks here in the US to really get our hands on the virus. And if anything, what COVID has conditioned the world to understand is that if you're a country that is host to an outbreak, or you're a country that has a new variant of an existing virus, the first thing that's going to happen to you is you're going to be isolated. I mean, before COVID, the idea of travel restrictions were an anathema and generally countries frowned upon it. After COVID, we've now popularized it. And it's something that once you go down that path, it creates other complexities, and it might foreclose other kinds of collaboration. So we're going to need to figure out ways to allow that to coexist, have more information gathering using our tools of national security, but still preserve the public health, the multilateral public health engagement, and the institution building that we know, and the capacity building around the world that we know is very important to the research community, the scientific community, sharing information where they can, where they will.
Yeah, a very good point, because we have seen where for a global surveillance system to be successful, there has to be early sharing of data. But if individual countries are punished by isolation they're going to be disincentivized through formal channels. I don't know, Eric, if you from your perspective, as you see these dynamics play out, how do you see that balance between the early sharing and yet creating a system that allows, doesn't punish systems?
It's a challenge, but I think that was pretty well outlined there of what the goal is. I think one thing we're missing, though, is that, there's two layers of prevention. One that, of course, having public health resources that are not just invested in, but have unity globally. The other is to have a pan virus preparedness. So we were very lucky. I think at the outset of our discussion today, Scott emphasized, I actually think it's a singular, most impressive biomedical triumph in history to come up with this these series of vaccines so quickly, so high efficacy and safety. But, it's partly because this virus is so susceptible. That is, anything, you go after the spike protein and you can get it, and the point is that we now know some people, like in South Africa and other parts of the world, they make incredible neutralizing antibodies. And synthetically, we are in a phase where we have structural biology, we have 3D structure, virology, immunology, that we can be so freaking smart to make pan-coronavirus vaccines that are structure-based, rational design. And we can also do that, as Scott touched on, for the other incriminated viruses. So why don't we invest deeply in that? And CEPI is starting to do that, but we really should get all over this, because once the horse is out of the barn, like happened in Wuhan, it's very hard to be, reactive. And we did it in lightning speed when you look back, but we can actually do better than that in the future because of the science now. And I think that's especially enthralling, and I hope that we will jump on that.
Really appreciate your time and your perspectives.
Yeah, thank you. Yeah, and before you go, I have a question to Eric. Eric, how do you manage to read all these papers?
That's the question we all have.
What I want to know is how you produce those great pictures of the articles. I cannot do that and then highlight them.
It's just old people have wisdom, Scott. Tulio, you thought I was a human, but I'm actually an AI agent.
Okay. It's a very good one. It's working well.
Thank you.
Eric, you are the best curator on Twitter of good content.
No, I appreciate it. That's really kind of you. That says a lot from you guys.